Welcome to the More Than Teeth podcast, where true health transformation begins in the mouth. Join your hosts, Dr. Michael Bennett and Cathy Bennett, as they explore the hidden connection between your mouth and your overall health. From sleep and airway disorders to nutrition and systemic disease, they're on a mission to help patients and healthcare professionals see oral health as the gateway to total well-being. So, let's get started.
Hello, everyone, and welcome to another episode of More Than Teeth, the podcast. I'm your host, Dr. Michael Bennett. I'm here with my sweetheart, Cathy Bennett.
Hello, everyone.
And I'm also excited to be here with Sherri Gunn, wonderful practitioner in the area in which I serve patients. Hi, Sherri.
Hi.
So glad you're here with us. For the listening group, I'd thrown a question out there. Is poor feeding in the 0 to 6 month range age for infants, is that just a phase or is that a red flag? So think about that. And I'm going to have Sherri give her a little introduction of herself and we'll dive into this topic.
Hey, hello, everyone. I love chatting about all things like this, so we can talk for days and hours. But I am the mom of 6 kids. I am a registered nurse and a lactation consultant, IBCLC, and a functional therapist. But I always say my greatest training has come from the home because that's what our kids do. They teach us a lot of lessons. And yes, I have been an RN for 23 years and a lactation consultant for 15 and a myofunctional therapist for 4. And I just graduated with my family nurse practitioner in August. So that was a huge milestone. And so I just keep realizing there's more I don't know and I need to know how to help my patients. And so I just keep learning and learning. So the question was difficulty feeding in 0 to 6 months, red flag. There's a lot of red flags that can happen with that question. The newborn phase is a difficult phase. I always say it takes a while for mom and baby to figure out how they're going to work together or not sometimes. And with each baby, it's different. Like when my 6 was one of my hardest nursers and I do it as a profession. So it's not I even knew all the answers and could get that one to work as well as I had hoped. So some of the red flags are long feedings. So even breast or bottle, we see parents just, oh my gosh, it takes 45 minutes to get them fed. And then they're only sleeping for 30 and waking up and doing it all over again. So marathon feedings, whether they're breastfed or bottle fed, is a red flag. So
how long should it be?
It depends on the age and the ability of the baby. So I'm going to give you an average 8-pound baby who's 41 weeks, whose mom has a full supply that flows fast. We're going to say about 30 minutes, give or take, right? Slower flow, harder to eat, maybe longer. Faster flow, easier to eat, maybe shorter. But we want around 30 minutes. And a bottle should take 15 or 20. It makes me nervous when a baby can down a bottle in 5 minutes. That's too fast of a flow or not working hard enough. And that comes with its own problems. But as far as the time of feeding, that's a red flag. Another red flag is clicking. So if I hear clicking at the breast or the bottle and it's a sound and it's usually with every suck or every other suck or a couple times of feeding, that's a red flag too, because that means that the tongue usually isn't touching the nipple the whole time and it's supposed to. So that's a red flag, is clicking or painful breastfeeding. So painful nipples, babies can get really a lot of blisters around their lips, which isn't normal. So it is hard when a very well-meaning sister or grandma or friend can be like, oh, it just hurt. Just push through it. You'll get through it. And while I agree that it's not the most comfortable thing in the world and there is a level of uncomfortableness a lot of times, I also hate the statement where it shouldn't hurt at all. And I was like, that's not true. It's usually a little uncomfortable, especially in the beginning. Pain, sharp shooting pain, pins and needles, pain after the feeding, between feeding, those aren't normal. So that's when you'd be like, okay, something's up. Let's go get this checked out. But even sometimes I always tell parents, I have some babies who are severely tongue-tied and mom has 0 pain at her nipples. So there is some times where there's nothing always. There's not like I can say, oh, if I hear clicking, then 100% of the time it's tongue-tied or 100% of the time it's XYZ. So we always just tell parents and moms especially to come get a feeding evaluation and let's figure out how you and baby are working. And a lot of times moms think things are going great. And they come to like, I just wanted to come get checked up. I really didn't have any questions. And then as soon as they start talking, they're like, oh, I thought that was XYZ. I hate when moms are always like, because it's always our fault, right? We'll always take it onto ourselves. If there's a problem, it's us. So baby doesn't like mine. I ate something wrong. What did I eat last night that upset my baby's stomach? Why I didn't get them fed in time. They were crying too long. They got air or they're fussy. And so anyway, we hear a lot of that. So getting an evaluation is always, and just to have somebody come and tell you you're doing a good job and you're doing it the right way and you're going to make it, like, that's always beneficial too, right?
I think that's the hardest thing for new moms because no one really talked about it, especially probably but especially when I was starting out. No one ever said, okay, breastfeeding is really painful. It hurts really bad.
Totally.
And so when I first started, I was like, wait, this hurts a lot. So I think it's really good that there are lactation specialists now that can help and let you know just like that. Hey, you're doing good. Don't worry. There is pain involved and it's okay. You can figure this out. Because it's true. We have 6 kids as well, and I nursed all of them, and some were so easy and others were not. I
Yeah.
love that, just that message alone, that it's unique to each child. It's going to be different every single time. Yeah.
Every single time. Yeah.
Yeah. I remember you saying, I shouldn't have eaten that chocolate.
Yeah.
That's bothering the baby
Yeah. Yeah.
or whatever.
Uh-huh.
Yeah.
I
And
love that.
sometimes things like that do. Feeding allergies is a true thing, and oral allergies is a true thing too. But one of the things that is difficult is that no, like if a baby comes in crying every feeding, it's okay. I have to assess all the different pieces, right? Like I have to be like, I had this baby that came in that's 100% bottle fed, but that would start crying in the middle of the feeding. And babies, especially newborns and littles, they're just very basic creatures. You feed them, you change their bum, you snuggle them and hold them so they feel like secure and warm and they sleep. So if they're crying, it's usually not just because they want to cry. It's usually something's bothering them or something's up. And this baby would cry after he started feeding, like almost immediately as the milk was going into his stomach. And so we talked about a lot of stuff. And the more I watched him feed and the more I talked to mom, I was like, okay, we've got some sort of food thing here. And so we need to start down that road to figure it out because he just could not be soothed. And a baby who's taking 4 to 6 ounces of milk and they have a full belly, they just, as soon as that full belly, you hit that full mark and they just pass out. They just cannot stay awake. So to have him be crying is sad. You just got to figure out, like, do we have a tongue tie? Are we swallowing air? So air is no bueno, like that hurts. And anyone who's had gas pains as an adult can bring the best to their knees. So no wonder the babies are sad. And there's a research article that aphasia is what is causing reflux, right? So we get a lot of dysfunctional swallows with tongue ties with resting. When you have that, you do tend to swallow more air. And so it's okay. Is this an air issue? Are we getting more air, which is causing pain immediately throughout the feeding? So we stop and burp a million times and get a better latch, change bottle nipples. They don't love marketing people because everything is, oh, this is most like breast milk, or this one's most like the breast, or the orthodontic, or all the things. Like parents nowadays are just overwhelmed with not only the amount of things that are thrown at them and the things that could and possibly would go wrong with a feeding or a baby, or social media does a great job at making parents feel overwhelmed. But I'm sorry, I forgot your first name already.
Kathy
Yeah.
Kathy.
and Mike.
Yeah.
Yeah, Mike, I know yours, but Kathy, when you and I had babies, there was like, you had what, 2 bottle options, maybe 3.
Yeah.
And maybe you got a handful of pacifiers. I remember with my first, Dr. Brown's had just come out with the pump. There was 3 pumps available when I started with my first, but then even with my youngest is 6 years old. So it's been 6 years since I was in the pumping breastfeeding world, and we only had 4 pumps available. And now every mom walks into my office and there's like a different pump and a different pacifier. This one's more like the breastfeeding. This one will get more milk out. And this one's, so the parents were like, there's all these different ways and things and the bottles. That's what I was getting at, is the bottle nipples. There's a million, and some look actually like a breast. And so they're trying to hold this breast to like the baby's face. And I was like, anyway, and we figure out, okay, baby's oral anatomy and function ability. If the baby is able to eat on a bottle better, get less air, and suckle better, then that will help the feeding. So I have a drawer full of bottles here, and it's been over $200 on bottles, just so that I could try all the different bottles. Because the moms, I went out and bought this bottle because it said it was like less air, and I went and bought this pacifier because it was this influencer loves it. She said it was the best for her baby, and her baby all of a sudden stopped crying all the time and had less air because they used XYZ. And so anyway, that was the bottle. We find that we have to figure out what is going to work for that baby. When a parent walks in holding a certain bottle, they're like, this is the only bottle my baby can take or likes. They just say, this is the only bottle my baby likes. And as they're like for that bottle, I don't even have to look in the baby's mouth. I know a baby's tongue tied because, again, basic creature, there is not a baby who doesn't want to suck. There's not.
Makes sense.
They can't suck or something else is up. So neurologically, anatomically, functionally, like that natural calming suckle reflex is designed for a reason, right? And that's to calm, and we can help soothe ourselves and our nervous system when we start to get upset. And so there's not a baby that doesn't want to suck. So having them come in and say, this is the only one my baby likes, we get to start the conversation of, it's actually the only one your baby can take. So that's why they're refusing all the other ones. It's not because the size of the nipple or the plastic that's used or whatever. It's that they functionally cannot take any other one. And they get mad about it.
Wow.
Makes sense.
So have you ever done a case and helped a mom and threw everything, kitchen sink at them, release tongue tie, lip tie, helped them and all the procedures, and they still weren't able to pull through? Just like in anything in healthcare, there's non-responders. Have you found a bottle nipple type that has worked more often than others? I'm sure people are wondering.
I know they are wondering. Okay,
Yeah.
that's a loaded question because we do have babies and that's the first thing we say when we are talking about this lip and tongue tie release is that the tongue tie that the pediatricians are looking for is the anterior tongue tie. So that's the tongue tip is tied to the gums. And so if they don't see that, they say, oh, your baby's not tongue tied. Even though there's a myriad of levels of tongue tie and function behind that, if it's not a classic tongue to tip tongue tie, the pediatricians, oh no, it's fine. And so the interesting thing is that I had one mom come in with her baby and her 3-year-old sitting next to her, and we're talking about the baby and we're talking about tongue function. And she starts to look at her daughter and she's like, can you look at my 3-year-old's mouth? Because the things is, it didn't hurt to breastfeed her. She gained weight. She grew fine. So those benchmarks were hit, right? So no one thought no one was concerned that the tongue tie was affecting things. And as small as a dental hygienist. So I knew she was tongue tied, but the doctor said it shouldn't affect these. She never slept through the night. She's 3, right? Like she had ear infection for the first year of life, which is a huge red flag for tongue tie stuff. And then she just had a difficult time feeding, not in like breast milk ways, but like that would take a long time to feed her and different things. And I look in her mouth and she did have a tongue to tip tongue tie. And I said, yeah. And they said it was mild. And so I was like, oh. And so then when we start talking about things, you can see her visibly get upset because this mom is such a good mom and an advocate for her kids. So she advocated for her child her whole time and kept getting told no. When, next baby, she comes to see me and we start talking about things and she's, oh my gosh. So we actually released her toddler and her baby the same day. But when we start that conversation of, will a tongue tie help release, like the release of the laser? And I always say every tongue deserves good function and the ability to have a full range of motion. That's like a base level low bar for me. I feel like that should be the standard. But going through all of this, there's a lot of variables. And I always say to parents, like, it could change and it could change nothing. And so that is the hardest reality, I think, too, is that no one wants to go through a procedure with their baby and not have the outcome we're hoping for. But anything in medicine, in my FNP, if anything, it showed me that this patient had a shoulder replaced or a knee replaced, hoping it would ease the pain, and it didn't. Or we tried this medication and it didn't change anything. And so with with tongue function and tongue tie releases, there's the risk that it doesn't change anything and that whatever symptoms they're seeing never go away. I have had some babies where it didn't improve and it actually made things worse, which is never what anyone wants to deal with.
Yeah.
And so that was really hard. And then I have had babies where it's like a light switch and it's like night and day. And all of a sudden there's a different baby in front of you and everything was magical and wonderful. And I love that happened for that parent. But then I also hate when they post on their thing, they're like, oh, I just got it done and everything's better. And you're like, oh, that's like the rare case where it's like perfect right away.
Yeah.
So I don't want to give false hope to my other patients who have to go through it because for tongue ties, and this is what I just preach so I'm blue in the face, is that the laser is the easiest part. 30 seconds a minute, we're done. It's the rehabilitation and the stretches you have to do to keep the wound open. So our parents, I'm like, if you don't feel like you can do the stretches 4 times a day for 4 weeks, then it's not worth us doing it.
I love that you are talking about that because I didn't know that until years ago when I don't think any of our kids have had to have tongue releases, but I know that several people that are acquaintances of ours, and I did not know that you have to continue to do exercises. So I would love for you to talk a little bit about that because I don't think most people know that. They just think, oh yeah, we'll just go get it released and that's it. That's all you have to
Yeah.
do.
Oh, I wish it was that easy. So the mouth is healed quickly, and which is a blessing because if we bite our tongue or we get a kinker, like it usually heals pretty fast. And then babies are super healers on top of that. So if we're talking about an infant that just got released, if you have 2 sides of a wound touching, the body is again designed to put everything back together, which I always say I love. And the rest of that baby's life, I want that body to put itself back together, except in this case, because I don't want it to go back to the way it was. I'm trying to change that. So if you have 2 sides of the wound, because it creates a diamond shape when you release the frenum, and if that is sitting there and that tongue only knows that it's supposed to stay down and doesn't know it's supposed to stay on the roof of its mouth all day, all night. So it's doing what it's supposed to do. And then even eating a little bit, those 2 sides are super sticky, like Velcro, that white granulation tissue that gets set down first, because it's supposed to be the Velcro straps. It's supposed to hold everything quickly, tightly, so then everything else can get filled in the hole behind it, right? Like that scab, leave that blood there for a second on your arm, it'll scab over to keep all the blood inside if it's a small enough wound. So the tongue's no different. And so when you have that white granulation tissue touching, I've seen diamonds close up so fast, a day or 2, where not only does, so if the diamond's like this, I always say we want to zip that diamond up so we grow that new tissue so it's long and we have that normal range of motion. But a lot of times what I'll see is it will close this way and then it will close this way. So if I go in and I look at under baby's tongue and I just see a line, I'm like, oh no, we reattached. And we have super healers, we call them. So we might have to do exercises more frequently, or we might have to do exercises longer than 4 weeks. But there's things we do at our office to try to mitigate that, the chance for reattachment. But there are some, I have had one baby where we released his tongue twice and it didn't improve anything. And his mom's a rock star. She did all the exercises like she was supposed to. And she did everything I asked her to do. And the massages and the craniosacral therapy. And she did everything. And now knowing that this kid is like a school age kid now, and he has dysphagia and he has to drink thickened liquids and he doesn't do well. And it was day 1 for him. And so that's the tricky thing is, Mike, you and I had said that like sometimes the things can mimic tongue type. And so unfortunately, there's not a way that I can assess an infant in the beginning to see if it's neurological, to see if it's a cranial nerve dysfunction or something else that's going on that's causing that dysphagia or the inability to swallow. So there are some babies where we'll watch and look, and if we don't see a restriction, we're like, okay, you're going to have a swallow steady, or we're going to send you over here and we're going to check all these boxes before we even discuss tongue ties. Because medically, I'm seeing some things that make me concerned. And that's where I have a really difficult time with mom-to-mom suggestions, because when a doctor or somebody has told the parent the baby's fine, tongue tie's not a problem, but she's using a nipple shield, the feedings are taking 30 minutes, she's having a bottle feed afterwards, that baby's gaining weight, but mom's working her tail off to make that happen. So it's not like baby's gaining weight and baby's functioning well. It's that mom's got 2 full-time jobs feeding this kid. And so even though baby's gaining weight, So she starts reaching out to peers. And then, oh, I had my kid had a tongue tie release. It changed everything. Why don't you go get an assessment? So then they go to their dentist or somebody where they have assessed them, and anatomically there's a tongue tie there. Like I can see that string. It's restricting range of motion. Yes. So they'll release it right away, which in actuality isn't always a good thing because we have to do some exercises before. Sometimes a floppy tongue that just stayed on the floor of the mouth isn't a good tongue to release. Sometimes we look at the baby and we've been starving for a month. I have a baby that walks in the door and it hasn't gained any weight in 2 months and is eating 6 to 8 times a day. Where the baby's starved and the mom's exhausted, and that baby's not going to heal well. That baby's not going to handle a release well. Like there's a few other things we need to do before we can release the tongue. So that's a hard thing as a practitioner, is that then I have a baby. I had one that a mom went to a dentist and the baby had the tongue and lip tie released, and that baby didn't eat for 2 days. She came to me on day 3 and we were finally able to get baby to eat, but that baby shouldn't have been released. So it's hard because I see all of it. And so there are times where I'm like, we have to look at the bigger picture of the baby and the family and the mom. And are they going to be able to handle the stretches? Can baby handle the procedure? Are we going to get the improvement? Because if I see the restriction, but I don't know there's a functional problem, or there is dysphagia, or we're swallowing air or aspirating every time, and then we put that baby through a procedure, that's like the last thing we want to do, right? So there's just a lot that go into it that nobody knows about or thinks about. And so it's hard because, again, it's not something I can just have a checkbox for and be like, we'll see this person because you checked all these boxes, or on Facebook or peer-to-peer. Or so like, I always just say, I wish tongue tied were like a broken bone, because like on the x-ray, you're like, yes, it's broken. Yes, we should fix it. And tongue ties aren't like that.
Yeah. No, I love that, because you bring to mind patients that I've seen where they've come in and they said, yeah, I need my child's tongue released, my infant's tongue released. And I will say, knowing that sometimes if they don't do their exercises or stretches, they literally can have that tongue tie reattached. The scar tissue can be even thicker and their tongue can be even more tied. And so I'll say, hey, I'm willing to do this, but it results in a team effort. I need you to make sure you promise to do the exercises. And I'll ask them 6 times a day, 6 for 2 minutes each time, where you're sweeping, knowing that, and sorry to let the secret out, but knowing that I'll get 3 times out of a day.
Oh, 100%.
Yeah, I'll go for 6, we get 3, but
yeah,
that's it. But if they say, I just don't have time to do that, and I'll say, we really might do this child a disservice if we release it without you being committed to that. So I've been known to say, sorry, I won't release your kid's tongue.
Yeah, I agree. I agree, because it is a disservice. And when that scar tissue gets worse, I've seen some pretty bad tongues.
And then lip ties too.
Yeah.
How do you view lip ties and tongue ties related to the latch?
Lip ties, they're more black and white for me. So that I like, lip ties are easier to look at and talk about. So depending on where the insertion site is and depending on the restriction that you can see on the lips for feed, the inside, the wet part of the lip needs to seal like a washer with a nut, right? So like it needs to seal on the breast or the bottle. And that wet inside lips should be the stuff that moves and slides, not the outside lips. So if we've got a humped lip that the mom will say, I just can't get their lip to flare out. Or I'll watch them on the bottle and their lips just tucked up. And then they have those lip lifters because that friction is caused with that skin that's not designed to be able to handle that kind of friction all day, all night. And so it's interesting because I think that I have released a handful of lips and no tongue. Not me personally, but like I've assisted the dentist, right? Because I didn't have my NP till now. So
yes, now you can.
Yeah. So when I say we, I mean he released the tongue while I held the baby. But we've got a couple lips and not a tongue, but that's very rare. It's mostly if there is a lip, there is a tongue restriction. And the lip, we see a lot of, I see more air and gas from lips than anything. I rarely hear clicking with lips sometimes, but I would say that the air is the biggest problem with the lip tie. If I have a baby with a lip tie, they're going to have a sad belly with air and gas. Those parents will be like, they're so gassy.
Very good. And I've told parents that baby's mouth should be, and correct me if I'm wrong here, should cover nearly the entire areola of the breast. where that nipple is basically at the uvula soft palate and in that mouth, and that lip, upper seal and lower seal lip should be created there
Yeah.
for a good
The
latch.
chin is what stabilizes the lip seal, and the tongue does all the heavy lifting.
Good tongue.
And it's actually not a correct statement to have all the areola in there. That's a male statement. and
That's a male
okay.
statement.
Uh-huh. And I know it's because you just haven't seen enough areola.
Yeah.
So because I have had moms with large areolas being like, they told me to get all the areola in there.
Yeah.
And I was like, you know what?
Poor baby.
You're never going to get all that areola in that baby's mouth, ever.
Yeah.
You're going to have to. So I just usually say breast tissue because we call it breastfeeding, not nipple feeding. So we do want the nipple in the back. I always just say basically swallowed down the throat. And then the breast tissue is what's actually in the front by the gums. And so then we have a good deep latch. But
That's a great way to say it.
Love that.
but there's a lot of variations. No two breasts are the same, even on the same mom.
Yeah.
Usually not, actually. So
Love that. So at the beginning of this, you mentioned the myth of that the latch, the feeding should hurt. And you said, no, not necessarily. It's going to be uncomfortable.
Yeah.
As you think about the other myths that come in when people come to you and they say this or that or whatever, what are some of those that you could maybe dispel for the group listening?
are we talking specifically infant?
Yeah.
Like breastfeeding?
Yeah,
bottle
mainly
feeding?
infants.
Okay. The myth that breastfed babies do not need to be burped. That one is definitely a myth.
Okay.
I'm like, when I hear that one, that's not my favorite. We always just say any baby that has air in their belly, breast or bottle fed, they're going to be fed. So we always give the baby an opportunity to burp. You might not always hear one, but we definitely want to give them the opportunity. What other myth? Oh, that your baby should sleep through the night by the time they're like 6 weeks. Or all the other, it's interesting because again, 6 kids, all very different personalities, all very different habits and health stuff that we've dealt with. And it's hard because while well-meaning, I know that some books and methods try to get babies sleeping pretty quickly. And it's for the sanity of the parent, 100%. I know that. I get that. But the problem is that as soon as we stop taking milk out of a mom's breast for longer than 6 hours, her body gets the memo to stop and to start weaning and drying up. So I'll have moms come to me and, I'm losing my milk, with my milk supply, or they're like, my milk just disappeared. I had milk and now I don't. And I'm like, okay, so we start digging, what's going on, what's happening. And their baby's sleeping 8 hours, 10 hours, 12 hours, because they've done these sleep training methods at very young ages. And so it's hard because I'm like, oh, actually your babies aren't designed to do that because your body's not designed to do that. So your baby actually works on a 24-hour clock, and your baby should be waking up every 3 to 4 hours for the first 3 months and then some, right? And then we get bigger. So we're taking bigger volumes. And so we can go longer, but we still should be waking up at least once in the night. So mom's not getting more than 6. Let's be honest, mom's never going to get 6 hours of sleep, but it would be a blessing if she could, because then it's the magic number 6. If we go longer than 6 hours without taking milk out of our body, we drop below 6 feedings in 24 hours, we're going to start weaning. So that's the age of 10 months. We're starting solid. Baby's got more food in their belly. They need the milk, but they're able to take bigger volumes. And so we can take 6 ounces at a time, and we can go longer at a time. And so then mom's dropping from 7 feeds a day to 6 feeds to then 5 and then 4. And then by the time they're around a year, maybe we're doing 3 or 4 feeds. But now I don't have to make all the calories for this baby. And so that's the natural weaning process that we're trying to happen like at 6 weeks old, because mom wants to sleep through the night. Again, I want to sleep through the night. Let's be honest. But that's the hardest part, is that the myth is that like your baby should sleep through the night, but then they come in with milk supply problems.
Perfect. So how long would be ideal for a parent to nurse their baby? If you're shooting for a target, what are you thinking?
As long as both parties are interested in it.
Yeah.
So if one of the parties is done breastfeeding, then both the breastfeeding needs to be done. So sometimes the baby's done and mom would love to continue, but it's just not happening. And that's a hard pill to swallow. Sometimes the baby, I'll breastfeed for years, and mom's actually, I'm done breastfeeding. So as long as one person in the party is done breastfeeding, like, it's good to be done. And so sometimes it's a lot sooner than a mom wants. And that's really hard.
I love how nowadays they have totally made it easier, at least in public places. Like you see some of those pods in airports, and
yeah.
they're so much better. I remember with our first 33 years ago, our first baby, and I was in the bathroom stall,
Oh,
sitting on the toilet, trying
yep.
to nurse or pump or whatever, and there was just no place to go that was private or whatever. So I think a lot of advances have happened that have been good and encouraging for breastfeeding moms. So that's a
Totally.
thing.
And like breast milk never loses its benefit. So if you're breastfeeding a 2-year-old or a 1-year-old, like it's not going, it's always going to be beneficial. It's a living fluid. It changes to baby's needs. That baby's sick. I can guarantee within 24 hours that mom's milk is going to make the antibodies specific to that baby and whatever that baby's dealing with. And so it's an incredible fluid that is always beneficial. And as far as like jaw development, we can get into that, and facial, craniofacial development, and the bottle versus breastfeeding and how that changes things too. So the CDC and the World Health, since I've been a lactation consultant long enough, like I've seen it say, our goal is 6 months, our goal is a year. Another one's like the first 2 years of life is encouraged. And so while our goal is always to have baby breastfeed as long as possible, the reality is that it just needs to be a working relationship.
Yeah, sure. And I think if we could have 25 podcasts related to the developmental side. As I think about, since I don't have direct experience nursing, only through Cathy, watching all that process, but I think about what I see when people come into the office and they have these underdeveloped faces, and literally rarely do people have enough room for 32 teeth, for their wisdom teeth. I just want to bring home the point that when it comes to facial, oral, structural development of the head face area, you absolutely need to get the best start in life with proper feeding. And the human breast is the actual size and creates the proper movement in the musculature to stimulate that development. So when a baby comes out, I've seen enough of them that they are cone-shaped. They're not human-shaped heads. How do they turn into human-shaped heads? That suckling process is part of how that happens. And so from a dental standpoint, I'm interested in the mouth growing properly because I want all 32 teeth to fit. And unfortunately, when you see the public, and I would guess, just being in practice 26 years, that easily 90+% of people do not have their wisdom teeth. They've been removed because there's just not enough room for them and for various other reasons. And so knowing that the mouth is the structure in front of the air pipe that's right behind the tongue, if it's small, then the air pipe's small, and it's small through the nose. And so what Sherri and I are doing as a team is we're not just allowing the proper feeding, which we are kind of opening up or unlocking the proper human development of the face, jaw, airway structures, and everything that's connected to it. And to me, that as a health provider, I'm really excited about offering so many other additional benefits to the procedure that we're providing, that there's so much value. What price do you put on that, right?
Yeah, there's no way. So that's the other part of the tongue-tied stuff. And that's how my journey began, because like I'm 6 for 6 tongue-tied kids. Like all of my children are tongue-tied because, well, they came from me, and I didn't know I was tongue-tied until I was 38. And I went to become a myofunctional therapist, and we were on a Zoom thing, and we had to assess each other's mouths. And so I like show my mouth, and they're like, "Oh, you're tongue-tied." And I was like, "I've been in the tongue-tied world. I have no feeding or speech issues. I'm not tongue-tied." And they're like, "You sleep with your mouth open?" And I was like, "Yes, I do. I sleep with my mouth open." And in the 90s, they didn't expand. They just pulled teeth and tightened everything back so that I didn't have an airway. And so then they're like, "You're the mouth breather profile." And so I'm like, I am the mouth breather profile. I'm like beaked nose, long, narrow face. This is how you develop with your tongue on the floor of your mouth. And so my kids had no hope. And it's interesting to see their variations of symptoms. I have a couple classic that tick all the boxes. I have a couple that don't tick hardly any, but that were enough that I was like, "Ooh, yep, we still got stuff going here." And then I had one who was like the worst tongue-tied, which was tongue to tip, no function at all. And the interesting thing about him is he's my baby, my number 6. And he was released by scissors at 3 days old. released by laser at 6 weeks old. So I got to do all those exercises twice and made myself a little crazy trying to get his tongue to rest on the roof of his mouth every time I got his mouth open and he was sleeping. Because as moms, we like to hyperfixate on things. And so every time I saw that mouth open, I was just shutting it all day long. But it's because his tongue's space. So I always say your tongue can't stay on the roof of your mouth if there's not enough space for it. And so in myofunctional therapy, as I was realizing I was tongue-tied and that I was suffering my whole life because of my mouth breathing and my poor sleep. And my husband always joked around that I needed more sleep than the average bear because I could sleep for 12 hours and wake up exhausted. And people would have dreams. And I'm like, what are you talking about? It's black when you go to sleep. It's black when you wake up. But like when you don't rest and get enough of that deep night sleep, you don't dream, you just survive. So anyway, so having enough space, and that's why you and I collaborate so well together, is that I can release, I will. So I can help a baby and assist releasing and give that tongue function. But if the tongue doesn't know to stay on the roof of the mouth, we can't grow a good airway and facial structure. And so we need that expansion and earlier than later because we want it to happen while they're growing, not after they're grown.
Right.
Like we don't want to do damage control. We want to help that child develop and grow. And it's been fascinating to see my son because again, 6 kids, I have a wide range of, my kids call themselves my guinea pigs because every time I learn something, I try it on them. And so then, yeah, I know. Like I said, our kids teach us a lot.
Yeah.
So then putting a palate expander in my oldest when she was 14 and how painful that was and the headaches and how like turning the stupid key, right? Like all those things, it didn't change her face shape very much. It gave her a little bit the more width for her tongue to rest on, but she was pretty much developed. We're set. Then we put the palate expander in my 4-year-old, now 6-year-old, and I turned that key and he's like, Mom, that tickles. People, that was weird. A weird feeling, but it wasn't like the pain. And then because he's growing and everything's still so malleable, like I watched his face shape just change and be so much better than what I had to deal with. And I'm looking at putting a Marpy in myself because I'm like, 26 millimeter palate is just not age well. And there's just not enough space up there. I've released my tongue. I've done my own myofunctional therapy. And so that's where it's like, it isn't one thing. We can't release the tongue and be like, and you're fixed. You're welcome. Have a good life. And it's not like we can expand the palate and be like, here you go. You're expanded. Now you're never going to choke on your food again. You're going to swallow the right way. Your teeth aren't going to move because you're going to not push on them when you swallow, right? If we don't do the myofunctional therapy and retrain the tongue how to swallow correctly, it doesn't matter how big the palate is. That tongue is still going to stay on the floor of the mouth. Yeah. And so that's why the myofunctional therapy, that's why the actual tongue release procedure, that's why the space and the rehabilitation of the face. It's so hard for me to see the benefit and have people still question and be like, oh, you don't need a tongue tie. And you don't want to put your baby through that. Why would you do that? And I also absolutely hate, and here is my soapbox. I have a few of them. Here's one of them, is that I hate when parents are told that they get to decide, does your child need a tongue tie release? You decide. And like a mom's still guilty. Again, we already talked about that, about everything. So for a mom to choose to put her baby through a procedure where it's painful and she has to do the exercises and she feels like it was her choice to do it because it wasn't medically necessary, but she's, I have my nipples hurt and I don't want to be in pain anymore. And so I'm going to put my baby through this procedure so that I'm not hurting or so that feedings are going better, or it possibly could affect things down the road. So it's just hard because as a medical community, we're like, oh, well, that a mild tongue tie, it could be a moderate. There's not, again, that broken bone. Yes, it's broken. No, it's not. The moms are like, is my baby tongue tied? Is my baby not? We can see the restriction. We can see there's dysfunction. We can see all this, but it's up to you. And so then they're like, wait, why is it the choice mine? Why is it that I'm the one that's having this? And so I would love to get away from that. And I don't know the right verbiage to use either, because there is times where I'm like, I recommend that we go through this tongue tie release procedure for your baby. I recommend it. Or I don't recommend it at this moment. And we need to wait. And these are the reasons why, and X, Y, Z, and we need to do some therapy and some other things like that. But I think it's just hard that we put that on the parents or on their shoulders.
That's totally unfair because it's the blind leading the blind. in a way. How would the parent know to decide whether the child needs it or not? I do believe in parent intuition. And I always try to inform and say, hey, whatever your gut tells you, you go with.
I do.
After you get
And I
all the
always tell the
information.
mom to follow her gut too.
Yeah, no, because it'll lead them. No, I agree. I think that's wonderful. Did we cover everything we wanted to today?
The only thing I was going to say is you said that it is not just one thing. There are a whole bunch of things that play into overall health and wellness, structurally everything. And that's where I have a strong background in nutrition and exercise wellness. And if you are not feeding your kids as toddlers good, durable foods to help with jaw development and foods, that's going to affect also. There's so many chemicals and additives in the foods nowadays, so much processed foods that kids get allergic and have a reaction where their nose, it has allergies and it swells and they can't breathe through their nose. So then they go to sleep at night, and because their nose is swollen, they can't breathe through their nose. So they're breathing through their mouth. So it's not always structurally, it's also what you are doing environmentally, how you're feeding your kids. And I always look around at church or the grocery store or wherever we might be, and all of us are guilty because life is crazy and you want to do what's most convenient, right? So buy that little pack of things that melt in your mouth. But I think if parents were educated and realized how important it is to give them a good carrot to chomp on and good apples to eat and things that really work their jaw, and then not so much processed foods, that goes in such a long ways. You breastfeed, that's so awesome. But then they start eating foods, and you've got to be mindful of what you're feeding those kids as they begin to grow and go through toddler and little childhood. So,
and that's the craniofacial development right there. I teach us introducing baby-led weaning or solid starts class. And we talk a lot about that and the development and jaw development and stuff like that. It's huge. Yeah, it's hard because we're so brilliant in moving things forward and fixing problems and finding a product style that's going to revolutionize things. And I always say in my solid start class, I'm like, baby food was developed in like the 30s. So what did we do before that? Like, how did babies eat? Because before there was processed baby food jars, there were still babies and they were growing into adults. There's a lot of different things.
Yeah.
So
that's so good. And you realize as you two, I'm listening to you two talk, that a team really is necessary.
100%.
Pediatric ENT or regular ENT, an allergy specialist, nutritionist, lactation, just primary care. We all have to work together in order to give these children the best chance, and parents. And so if the parent's listening to this thinking, okay, I'm totally overwhelmed now. Where do I start?
100%.
You just got to go to somebody who has, like us, who has a background in how development is, that it does matter how we swallow, how we breathe. Nose breathing is always best. Mouth breathing is what you do when a grizzly bear is chasing you, and trying to breastfeed.
Yeah, you gotta have a backup plan.
Got to have another hole there to breathe through. For sure. Yeah, and that you need to work together with other providers in order to get these outcomes where you get healthy, happy people. When you speak about formative years, the 0 to 8 years old, that's so crucial for neurological development. And I so often hear the myth that we can just wait until 12 when all the permanent teeth are in to do the expansion. And I think, do you want neurological development now at age 4, or do you want to wait till 12 when that neurological development is mostly completed? Forebrain, not so much, but we just have to get that perspective out there. So,
and as a mom, again, whoever's listening, those moms that are feeling overwhelmed, welcome. This is where we live most of our life. And it is interesting because my son, one of them, we used to joke, like, where is he going to wake up in the morning? Because he was like all over the place. And he had some hard years, right? It was like really hard. And he'd wake up angry, and there was lots of like meltdowns and interactions with siblings that weren't always the best. And but I felt like his personality wasn't like that. And so it was really frustrating to me. And then I started this deep dive into tongue ties, and we expanded his palate and got his tongue tie released. And I, like, the complete opposite, like the kid that he is now is not what he was on a trajectory to be. He was on a trajectory to be a medicated, difficult child that it was hard because he just wasn't sleeping. And so a lot of times these kids like that aren't sleeping and are having meltdowns. As an adult, you're tired and you snap at somebody. So as a kid, there's just no hope. They need extra sleep. And so then we're not sleeping well. So I always tell parents, like, the red flags for, and we can talk some more on another podcast if you want about the pediatric sleep disordered breathing, because that's another thing I love to talk about. But if your kid's breathing through their mouth all night long and they're restless and they're tired and cranky, let's figure out, let's find out why. Do I have all the answers? Heavens no. Will I try? Yes. Will I ask somebody if I don't know? Yes. That's like the team approach, right? Like the ENT or that facial therapist, or I have one foot in each world. And so we'll go woo-woo and acupuncture and all the other things as well. We'll do all the other medical parts we can. I think there's a healthy blend of both worlds that can help treat the body, because it's a whole thing, and it's not just nutrition, but it's not just sleep, and it's not just airway, and it's not just tongue. I feel like there should be like a head, shoulders, knees, and toe song. Like, it's not just this, it's not just that. And so anyway, it's just, there's lots of specialties, and the poor parents that get so confused and so lost because the specialties will contradict each other.
Yeah.
And they're like, this person said, how many times this week am I going to hear my pediatrician said my baby wasn't tongue-tied? And then you're sitting here telling me he is.
Yeah.
And so then I was like, did your pediatrician sit and watch your baby eat for an hour at your breast? Did your pediatrician put his hands in your baby's mouth like I just did? Did your pediatrician go through the Martinelli screening tool and teach you about tongue ties? No. Okay, then he was going with what he knew, and that was a very small amount of information, right? So that's where it's like, if we have the team that can talk to each other as professionals, and then also help the parents, because we're all talking about the same issue in the same way, then it does wonders. And that's like when we come in for a toddler, an older kid, I'm like, you know what? I am so glad you came for an evaluation. I'm going to see you in about 2 years, because first you're going to go to the ENT and we're going to get tonsils out. Then after that, you're going to go to dentist, you're going to get expanded. That's going to be a little while. And then after that, you're going to go to myofunctional therapy. And then I will see you.
Mm-hmm.
So.
I love that.
Team approach, exactly.
Team approach, yes. And we will definitely have you back, because we have lots to talk about to share.
Yes, we do.
So,
yes, we do.
Thank you so much for your time. Appreciate you sharing. Any parting words you'd like to share?
Oh, yeah, don't give up.
Yeah.
That is
That's
great.
know,
Yeah. We're our
we're-
children's best advocates, aren't we?
Yeah.
And whatever
Yeah.
we can do to help them heal and live a good, healthy, holistic life. That's what we
Totally.
wanna do.
Yeah.
And just do your best. Like I always say, I've never been a mom that thinks she's doing a good job.
Mhm.
So, it's just, we're all doing our best with what we've got on the day we have it, with what we have.
And dads support the process.
Oh, dad's 100% are
Yeah,
great.
you got to be there.
I can only give the mom perspective.
Yeah.
Thank
Thanks
you.
again.
You're welcome. Okay, bye.
Bye.